Sharing. Hello, can everybody hear? So may I start now? Okay, so today I'm going to share three cases with you all. The cases might actually be simple, but I just want to deliver a message across, and there might be some details about in the aspects of ICU, but I hope I can bring along a message at the end. So case one is a 69 years old COPD pneumonia and intubated and sedated, and the sedation was tailed down on day 3, and the patient has experienced patient ventilator desynchrony, and because of that, we have put in a NAVA catheter for NAVA ventilation. For your information, NAVA is called neuroventilatory assist, neurally adjusted ventilator assist. Essentially is a mode of ventilation that require patient spontaneous effort, but the mode of ventilation is triggered by the diaphragmatic EMG, so to optimize patients' breathing. As you can see, this mode of ventilation requires a special NG tube. The gastric tube has actually incorporated some ECG leads in the catheter, and when you put in the catheter, plug it into the ventilator, then the ventilator would display the EEG signals onto the screen, and at the same time, it would show the position of the electrodes that is sensing the diaphragmatic EMG most. So just to illustrate to you that in the right upper picture, the white curve is actually the diaphragmatic EMG, and the yellow curve is the pressure time curve, and the lower curve is the flow time curve. So you can see actually in a period that the diaphragmatic EMG rises, which signifies inspiratory effort, there's a period shown by the red dotted line that actually there's still no flow and still no pressure delivered to the patients. And when the patient's breathing effort is starting to expire, you can frequently see that there's a delay as well. So the expiratory phase actually started much lower than the EMG signal showing expiration. So neurally adjusted ventilator assist has actually been shown to reduce durations of mechanical ventilation, increase ventilator-free days, and possibly length of stay in certain subgroup of patients. So this is just to show you how the machines work. When the catheter was put in, it would show the ECG signals. So because it's sensing from the esophagus, there will be sharp spikes of P wave followed by sharp spikes of QRS. And as you can see, as when you go along to the tip of the catheter, the P wave actually disappeared, and the QRS magnitude would decrease, so which signifies actually the catheter has just crossed the diaphragm into the stomach. So frequently we are looking for the pattern that the most distal ECG tracing has the absence of P wave, and you can see the color demonstrating the purple color is actually demonstrating activities of diaphragmatic EMG, and you can see that in this tracing actually is the middle electrode that is sensing the diaphragmatic EMG, and it signifies a good position of the catheter. And according to the industry recommendations, when you look at the left diagram along the path on the right, you can see that intubate CMV, optimize CMV settings, and then insert EDI catheter, and then identify EDI, and then confirm stable EDI more than 2 microvolts. So the industry is actually just is recommending at least an EDI of more than 2 microvolt. Most of the time it would be around 10, but sometimes in certain patients the EDI can be quite low in those with poor diaphragmatic activity. So back to our patients, we put in an EDI catheter, and this is the signal that we get. You can see that the EDI signal was 2.5, and the white little dot is actually representing the mechanisms of the trigger. You can see that the breath is actually now EDI trigger, and this was accompanied by the first rise in the peak of pressures. But you can see that the EDI position is quite small, and then even when the EDI signal drop, which signifies expiratory signals, the flow was stopped and the pressure drops. But you can see that even after the pressure drop, there is another pressure trigger along the pressure time curve, and this was followed by a second wave of the inspiratory flow, and followed by an expiratory phase. So here, what has happened actually, we are not quite happy with this waveform, but it requires up a level of NAVA of up to 10 to deliver an effective tidal volume. So we are sensing something wrong, although the mode is still triggering the ventilator, but we are not quite happy about that. So we took an X-ray and we found that actually the catheter is in the bronchial position, and that explains the poor waveform. And when we put it again, and now we position, and we have obtained a very good EDI signals, and accompanied by a good rise in pressure, and then drop in the EDI drop in pressures. So actually, we try to look a little bit into this issue, and we have think in another way. So can actually the using of this NAVA mode, this EDI catheter, used to predict the correct positions of NG tube, and we try to do a little bit of literature search. And actually, there is some people describing using these techniques for confirming NG position, but it's in pediatric because NAVA is quite quite a mode that is actually propagated in the pediatric neonatal ventilations. So and actually, there are papers describing this. So what I have think is actually in some critically ill patients, sometimes we might not have enough time to confirm NGT position by chest X-ray, and some medication may be urgent. One of the typical examples is to load the Plavix for urgent PCI. So this lesson might have given us some insight into another use of this NAVA mode of ventilation in confirming NG tube. So second case. So it's a 44-year-old man with a right vocal cord palsy, recurrent aspiration pneumonia, and he had resistant schizophrenia. So during the hospitalization, he requires multiple antipsychotics for symptoms control. and that has caused excessive somnolence, and he probably had some silent aspiration and consult us because of carbapenem-resistant Acinetobacter pneumonia. So he had quite a bit of sputum. So on day 5 in the ICU, actually, one of the heat moist exchanger is changed to a heated humidifier to improve humidifications. And then on day 6, we tried to wean him to pressure support, to a pressure support ventilation, and he required a moderate, low to moderate pressure support of 10 above a PEEP of 6. And then on that night, the ICU senior was consulted by the on-call doctors and informing the ICU senior that the patient is fighting the ventilator. So at that juncture, the patient was recommended to the on-call doctor was recommended to resedate and paralyze the patients. And then nothing seems to happen, and the problem seems to have settled through the night. And in the morning, so we review the patients, and looks like he was in good ventilation. You can see after sedate paralysis, he was put on SIMVP RVC mode plus pressure support, and with a set tidal volume of 400. And a PEEP of 6, and it delivered a tidal volume of around 372 to 433, respiratory rate between 24 to 34. And seems everything has settled, so this patient was tried weaning again and was put on pressure support again. And you can see seems to be quite good in the morning until 1 p.m. The respiratory rate goes up a little bit to 31. And then the FiO2 needs to be increased to 65% at 3 o'clock. So, and then it was found that the patient was actually breathing a little bit, was actually a bit difficult in terms of the breathing. And this is the waveform recorded on the ventilators at 3:30. So here in the ventilator, it was recorded the pressure was 28 and a PEEP of 20. And when you look at the waveform, you look at the flow time curve. The upper one was the inspiratory, and the below the horizontal line is expiratory. So you can see that actually there are periods of inspiratory flow followed by expiratory flow. But when you compare it to the pressure curve, it was actually the expiratory phase which shows an increase in pressure, and then when it looks like during inspiration, the pressure dropped. And when you look at the falling time curve, actually there was no breath delivered. And only very intermittent is one breath for this. And then a few seconds later, same thing, during expiration, pressure rise. During inspiration, the pressure dropped. And until the pressure was dropping to about like 16, 17, if you look at this scale, then it seems that there is a trigger as shown by the white dots, and then a pressure support of about 10 was delivered, and then followed by a rise in the pressure again during the expiration. And here there is some tidal volume delivered. So what happens here? We look at the scavenger. We found that in COVID, we routinely would use a scavenger to try to minimize contamination of the environment. So in the expiratory exhaust port of the ventilator, the we routinely connect a scavenging system to connect it to the hospital vacuum by using this device, and we found that the reservoir bag was quite distended. So we think that we immediately recognize there's some blockage in this scavenger. So what we do is we try to remove this bag, and actually once we remove it, we obtain very good waveform, and we try to put it back again. The distension was resolved, and along with this, we also find quite a bit of condensate, some water collected in the tubing. So some water is actually collected in the tubing. And then we look at the supporting data to support our hypothesis. We look back at the time when the doctor informed us. So actually, when you look at it at 20:20, 10 o'clock at night, the PEEP was 37 and actually higher than the peak pressure of 31.8. And at that time, there's also no spontaneous respiratory rate, and all were delivered by a mandatory rate of 10. Actually, it's a backup rate by the ventilator. And then you also look at the end-tidal CO2. The end-tidal CO2 was 90 at that time. So which signifies either there is hypoventilation or there is actually rebreathing, CO2 rebreathing. And you look at sometime earlier at 7 p.m. Actually, there is an episode which hasn't affected a lot with other ventilatory parameters, but the end-tidal CO2 has risen to 76, and that is intermittent as well. So signify the problem was intermittent. And we look a bit more details in the numbers. Actually, the volume showing actually there's no mandatory rate at that time. There's no spontaneous rate at that time, just over mandatory rate of 10. Now, so for you to have a better picture of what has happened, this is the structure of the scavenger, and you can see this is there's a tube from the ventilator exhaust, and then it works with a pin valve. So normally this pin rod valve is closed. So this is to protect the ventilator from the excessive negative pressure from the suctions to avoid damage. But when the gas fills up the bag and the bag becomes more distended, then actually the bag is filled and the short axis of the bag shortened, and this has actually raised up the pin. You look at the diagram C here. Then this raises the rod valve open, and then the gas was escaped to the scavenging. So the ventilator exhaust gas was vacuumed. But what happens here is we have added the heated humidifier, so the absolute humidity of the circuit inside the circuit is increased. And for the patient's breathing circuit, actually, because the tubing is heated, so the higher absolute humidity does not cause condensation. But here, the tubing from the ventilator exhaust is actually not heated. There's no wire, no heating wire inside. So condensate tends to form, and it gradually collected over the reservoir bag. And now here you see when there are condensate which has collected in the bag, it causes a weight drag, and this has actually maintained the long axis of the bag despite. Let's see. So so sorry. So now the long axis of the back remains, and the rod valve will remain closed, and this has caused an expiratory obstructions of the circuit, and this also caused the pressure to build up during expiration. The patient is breathing against a closed circuit, so that explains the rise in expiratory pressure. And only when the pressure drops during inspiration, when it drops below the set inspiratory pressure of the ventilator, then the ventilator can deliver a breath. And the rebreathing from the reservoir back caused the very high end-tidal CO2. So we try to prove it. So we have used the ventilator, and then this is the waveform, and then we slowly pour in water in 50 mils of increment, and then when the volume reaches 800 mils, then we observe a sudden change in the pressure time curve. Here you can see somewhat resembles the pattern of obstructive lung disease with a very low expiratory flow. And probably because of that, it has distended the test lung, and therefore the test lung compliance drop, and it causes a rise in the inspiratory pressure. So we were not able to replicate the scenario with spontaneous breathing patients, but this is what the best we can get. But I think it supports our hypothesis of the problems. So case 3 is 61 years old man, and we received a crash call for severe respiratory distress, and his saturation was about 50 to 60, and the chest X-ray showed APO pattern. So the on-call goes and attend the patients and preparing for intubations in the ward. So he was pre-oxygenated with the back valve mask, and also to ensure that doesn't improve a lot, and then to ensure airway patency, an oral pharyngeal airway was put in, nasal pharyngeal was put in, and the nasal cannula was also maintained. But then despite this maneuver, the SpO2 still remained to be 70%. And I can reassure you, actually, at that moment, the mask has maintain a good seal with the patients, and actually there's no circuit leak. So what would you think at this juncture? So would you just inject the induction agents and proceed with intubation immediately? Alternatively, you might want to check. So check the oxygen source, check the reservoir back, or you would ask for an alternative resuscitation back, or ask for a PIP valve. So I would say there's no absolute correct answer, but probably all are quite reasonable. But in this particular juncture, that doctor asked for a PIP valve. So what happens here? That doctor asked for a PIP valve because he noticed that actually the ambu bag was not the one he is used to be using. So he is asking for that, but at that time it was not available, so intubation has to be proceed. And then once after the intubation, the SpO2 has back to 100. So we look at what actually happened here. Now the resuscitation bag in NTEC hospital mostly in most of the location is using a disposable version, and disposable version because it's coming from central storage, central supply from the hospital. So a majority are using 1 or 2 brands, and we take a closer look at the inspiratory expiratory valve. So here, some of the model actually has a configuration of a duckbill valve, but there are options of with having an expiratory disc or without an expiratory disc. So in the top panels, when there is an expiratory disc, so when you provide a manual breath to the patient, the oxygen would goes into the patient. But during patient's expiration, the duckbill valve would be closed, and therefore the expired gas would have to leak through the expiratory disc, and it goes out. But looking at the scenario that do not have expiratory disc, so during inspiration, because there is no expiratory disc, so if there is spontaneous patient's effort, then not only oxygen will go to the patients, but room air is also entrained to the patients. So this would dilute the FiO2 delivered to the patients. And during expiration, is somewhat similar, but there's no expiratory disc, so the resistance would be lower. And alternative design is the disc valve. So oxygen would go in, and then when the patient expires, it goes through the expiratory port. So indeed, we look at recent papers. We found that actually different models of resuscitation bag has quite variable performance in simulator settings. So this is one of the paper that actually shows using a mechanical simulator simulating spontaneous breathing. And the performance for delivering FiO2 can be quite variable. So you can see the Ambu and Lado version predominantly can deliver FiO2 somewhere between 90 to 100. But when you look at intersurgical or the O2 smart bag, FiO2 can be as low as 40%. So, and our NTEC ICU group has also performed an experiment. We use the back valve mask that we are currently using in NTEC hospital, and we asked volunteer to perform this experiment, and during normal tidal breath using this device, you can actually see the FiO2 delivered. It's between 80 to 90%. But then once during the phase of deep, fast breathing, the FiO2 would drop abruptly to 40-50%, and this is consistent with previous finding. And we tried a similar setting, but with the addition of a PIP valve. Then the FiO2 can be maintained at about 80%. We also try to use nasal cannula in addition to that resuscitation bag, and it also sort of partially alleviate these problems as well in the setting of without the PIP valve. So. Indeed, the NTEC Resuscitation Committee has formed a panel, and they're looking into procuring different models of resuscitation breathing bag because of this shortcoming of this model. But in the meanwhile, there's some interim suggestions from Resus Committee, like. We will recommend the use of a PIP valve as an expiratory disc, and even the patient is breathing spontaneously using this back valve mask, gentle manual CPAP should be maintained, so that the purpose is to maintain the duckbill valve to be open, so that there's less air entrained through the expiratory port. So to conclude my talk, I use montage that is taken from the Zoolander. Is the orange MacBook scene. The files are in the computer. So whenever if there is an equipment that do not actually operate as what you expect. I think better hold your basic instinct and try to think twice before a very impulsive action or first instinct action. A lot of time, the machine is quite smart, and there must be something else that is happening. So I think this is what I want to deliver to tonight, and I hope you guys enjoy this talk. So is there any question? NAFA, there is one paper which I have shown. Is actually a randomized trial showing in hypoxemic respiratory failure, showing that the mechanical ventilation's duration has been shortened, but the data is still not conclusive, and it's just one small randomized trial. Majority of the study is showing there is an improvement in synchronization, and this is the endpoint for majority of the study. So there's in ICU not actually a lot of paper that can show superior clinical outcome. So is there a takeaway for us medical students? We are honestly not very familiar with details of ventilators to understand the components malfunctioning. So is there something you want us to remember? I think when you manage a patient or we manage a clinical scenario, you would have something that you would expect to occur. But when something occurred that you didn't really expect, then you might think there might be some error, or there might be something like some piece of equipment that do not work. But a lot of time, actually, the things would make sense, and there is actually something wrong. A lot of time is actually it might be related to equipment, it might be related to some pitfalls, it might be related to unusual patient conditions. So whenever you see something wrong, I think that do not happen as expected. Just try to think deeper and try to understand. And if you know your equipment well, then it helps a lot in understanding what is happening wrong. So if there's no more questions, then maybe I will finish the session.